is ready online? Yeah. Yes. Okay, wonderful. So thank you. Welcome everybody here in person and online, remote, for this wonderful seminar today as part of the 330 NIEHS Center here at Columbia University. So we are very honored to have with us Dr. Keeve Nachman. And Dr. Nachman, he is the Robert Lawrence Professor in Environmental Health and Engineering at Johns Hopkins University, Bloomberg School of Public Health. That I think it's a huge honor to carry that name. Bob Lawrence was an incredible professor that all of us who went to Hopkins have the privilege to work with and learn from. So that's amazing. And Keeve is, in addition of being a professor in environmental health and engineering, he also has a joint appointment in health policy and management. He's the scientific director of the Center for a Livable Future. Is that the right title? Maybe not.
Associate director. Yeah.
Associate director for the Center for a Livable Future, which is a very, very important center at Hopkins that does a lot of important work for better health, environment, sustainability, with an important focus on food systems. Keeve is also part of the Risk Assessment Institute, the Risk Sciences and Public Policy Institute at Hopkins. And actually, Keeve has tremendous experience and leadership in risk sciences. Also tremendous experience and leadership in risk communication. Keeve, we are always, I think you are a role model for all of us in this field. You really have incredible talent in how to communicate complex concepts to all types of audiences. So that's it's been an honor to always learn from you in that way, in so many ways. And Keeve and I met in, I think, 2002 or 2003. We were both PhD students, and our common mentor, Ellen Silvergold, put us together to work on a systematic review and on arsenic and cardiovascular disease. And that systematic review made that we became friends, and because we had to review lots of papers together on a very kind of complex topic. And so since then it's been amazing. And Keeve, I'm going to stop because I could keep talking for a very long time. So thank you so much for coming today.
Thank you so much for having me. It's always a pleasure to be here, and I'm really happy to be back. I came here a long time ago and met with Joe. I'm trying to figure out how many years ago that was, but lots.
It was a super fun seminar. You talked about Roxarson.
Oh, wow. So I didn't remember that I did a seminar on that. I thought we just had a meeting. Okay, so I'm not going to talk about Roxarson today. I'm not going to talk about food at all, which is unusual for me. But I'm going to talk about risk assessment today. Does the clicker work? The clicker does not work. Okay, I'm just going to do this. So my field is risk assessment. I'm showing you 3 reports from the National Academies here. I'm not going to go into each one in detail, but this one on the left really established and formalized the process of risk assessment. It came out in the early 1980s. And back then, when we thought about risk assessment, we thought about dealing with one environmental hazard at a time, usually through one pathway or one route at a time. And it was this reductionist process to do the best possible job we could with that one chemical, kind of ignoring the rest of what was going on in the world. And over time, we started to recognize that there were real limitations to that approach to protecting public health that we were really narrowly focusing. And we kind of introduced the idea of cumulative risk assessment, thinking about we're actually contending with many environmental and other stressors all at the same time that may collectively compromise our health and make us less resilient to exposures that we incur. And more recently, we've recognized that, hey, you know what? We might not be able to quantify the combined effect of all of these things at the same time. And we need to manage risks despite that limitation in our ability. And so I want to talk to you today about some ways that we've tried to take the science that's really lagged behind our thinking in the context of exposure sciences and in the context of doing a better job with these mixtures of chemicals, cumulative risk assessment. So every time I come here, people want to talk about risk assessment, which is nice. And so I just thought I'd briefly show the paradigm that we're still operating under, which came out in the Science and Decisions report in 2009. And I wanted to zoom into the 4 major steps that we focus on and just kind of restate those for people who aren't super familiar with risk assessment. The first step in assessing risk from an agent is that we need to understand the relationship between exposure to that agent and whether or not it elicits some adverse health outcome or multiple adverse health outcomes. And that really is an evaluation of evidence that's qualitative, and that's called hazard identification. The next step is dose response assessment, where once we've decided that yes, there is a relationship between that agent and some outcome, we try and quantify the nature of the dose response relationship. Then recognize, oh, my slides are messed up, sorry. Recognizing that we have to deal with people in the equation, we need to characterize the extent to which a population has contact with that agent. And then finally, we bring it all together to forecast how likely it is a population or a subgroup is going to get sick from the scenario that we've described with the agents and the remainder of this paradigm. So that's risk assessment. So I'm going to zoom in on 2 parts of that paradigm today with 2 case studies. When Anna invited me, I had such difficulty figuring out what am I going to talk about. I have so many things I want to talk about. And so I made the very poor choice of doing 2 things instead of 1. So I hope you'll humor me. And I also hope we get through all my slides. First one I'm going to talk about is an exposure science project that was funded by the EPA called the Innovations to Generate Estimates of Children's Soil and Dust Intake, which is a study aimed at designing new methods for estimating exposure to dust and soil. And I'll talk about that in a moment. And then the second project is a project that's funded by the Bloomberg Philanthropies that involves trying to characterize the cumulative burdens endured by populations living in the shadow of large-scale petrochemical processing. And I will try and wrap those things up by talking about what it means for the field of risk assessment. Okay, first case study. So this was my inspiration for the first project. These are my boys. This was a really long time ago. It was back when Anna and I had our children together in daycare at Hopkins. But when they were this young, my wife and I were also relatively young. I was new faculty, she was a postdoc. And every day our kids would wake up at 5 in the morning and we had to be with them and we were just fried, right? And so what they would do, this was terrible, they would play on the floor and they'd go into that cabinet there on the left, take boxes of cereal out, dump them on the floor, and then eat them while we slept on the floor. And it's okay to judge our parenting skills, but it made me think, rather than do something about it, I wondered how much dust are they getting in their mouths and what does it mean? And it made me think about my training in risk and how challenging it's always been and how low our confidence was in our estimates of dust ingestion rates. And so when the EPA announced a couple of years ago, we're going to fund people to develop new methods to estimate soil and dust exposure, we were all in. So went for that grant, got it. I don't know why my font is messing up. I really apologize. But one important thing about soil and dust ingestion is that we recognize in the field of risk assessment that when we're doing a risk assessment that's multi-pathway, it's often the case that soil and dust exposure, especially for children, are real drivers of exposure more than many other pathways, especially for a lot of chemicals like lead, maybe PFAS, PBDEs, et cetera. So really important pathway, but low confidence in our current understanding of what those ingestion rates are. But regulatory interventions like setting standards for chemicals and dust, lead is really the front line of where we've done that, but we should be doing that for other chemicals. They rely on high quality estimates of soil and dust ingestion, and we just don't have them. And so to date, we've tried to do this. One of the most popular ways that we've done this is through mass balance estimations using metals, and they don't work well. And so EPA was really excited about coming up with newer ways to try and quantify what these exposures look like. So, wow, my slides look terrible. I apologize. Okay, so EPA has this cool model that they've developed. It's called the Stochastic Human Exposure and Dose Simulation, or SHEDS, and they've adapted it for soil and dust. And it's a neat model, but unfortunately, a lot of the underlying data that support the model, the inputs there on the left, are highly uncertain. And so our grant aimed to improve 2 of those major inputs, and I'm going to talk about one portion of it today. So what we needed to better understand is how children spend their time and what their activities and their micro activities, so hand-to-mouth, object-to-mouth behaviors, look like in the context of those different activities. That's what we needed to do. And if we do that, we can actually get a lot closer to modeling ingestion exposure estimates using some other data that we feel a lot more confident about that will allow us to rigorously estimate safe levels or safer levels of chemicals in soil and dust. So we proposed a study that had 3 different aims. I'm going to focus on one of them today. So the first aim involved using smartphone surveys of parents repeatedly over the course of the day to figure out over a time scale of 24 hours how children spent their time, where they were, what the activities were, what they interacted with, what types of flooring they spent it on. And so we developed these estimates as inputs for that previous model I showed you and published that. So I'm not going to talk much about that today. Then we had this microactivity assessment, which is what I'm going to spend most of my time today talking about. So I won't say much about it yet. And then the part I'm not going to address today also is we worked with this amazing chemist named Karsten Prasa at Hopkins, whose specialty is non-target analysis. And we worked with environmental and biological media to try and identify a tracer compound that we can use that's better than using a metal, that would allow us to measure something in stool or in urine that would be a good indicator of soil and dust exposure. And that work is still underway. And maybe you could invite Karsten to come talk about that. But anyway, I'm going to talk about microactivity assessment. So this is our overarching framework for how we did it. And I'm going to walk through each of these steps in greater detail. But in short, we collected video. We had people look at it. We had a computer look at it. We analyzed the data. We validated the computer model. And we were able to generate distributions of these microactivity factors that are a really key component of the soil and dust exposure models. Okay, so we went into the grant thinking we would be using a Hopkins cohort that ceased to exist basically the same month that we started the grant. So that was very frustrating, and we had to recruit from the ground up. I will say, for those of you that are experiencing challenges with participant recruitment, we used a company called Build Clinical that we paid about $1,000 a month for, but they used web remnants from people to identify people who were likely candidates to participate in the study. And they skyrocketed our enrollment in a very, very short period of time, which was kind of amazing. But we recruited in Baltimore primarily for this because we didn't want to drive very far because this involved home visits. And our demographics, unfortunately, largely reflected the higher educated and Hopkins affiliated community. But I think for what we were trying to do, it wasn't the end of the world. But again, we were aiming to develop methods and not necessarily characterize the full distribution of population behaviors. So as a method development study, it was okay that our population was not as representative as we would have liked. Participants for the microactivity study had to be between 6 and 18 months of age. And of course, their caregivers were the ones to enroll them. And when we did this, we collected some additional data. So we used the ECHO demographics form to make sure that what we collected was comparable with other studies. And we also used something that has been cut off from my slide called the Ages and Stages questionnaire. Anybody doing pediatric research and familiar with that? There are tools within that questionnaire that allow for the assessment of fine and gross motor skills. It's very easy. Clinicians use it. It's a handful of questions, but parents could very easily do the same thing. And it allowed us to try and assess whether the stage of a child's development, which is not necessarily intrinsically linked to their age, influenced their microactivity behaviors. Okay, so when we went into homes, and it was, this was a tough sell for some people. Can we come to your house and set up a bunch of cameras and film your child? And the third aim also involved collecting their dirty diapers, which I think was the more tricky sell. but we somehow found people who were willing to do this. So we would set up an appointment to come to their house. We would send our RAs, and we used cameras. So we used GoPro 9 cameras, which in working with my computer vision colleagues, we learned were able to capture video in a way that they could make good use of it. We would go into the house and set up the cameras from 4 directions around the child in the place in the house where they would spend the most time playing. And our hope was that despite the fact that we're setting up equipment in their homes, that we are not alerting a baby to the presence of new and foreign things in the house. And we were largely successful in doing that, but it took a bit of training of our field staff to make sure they didn't interact with the baby, and the presence of the caregiver was very helpful. And so we filmed each child for about 20 minutes. We broke it into 2 sections, an unstructured play, which was just do whatever they normally would do. And then we thought it would be interesting to give them a new toy. We call that structured play because we think, you know, the way a child experiences the world when they're younger is that they put things in their mouths and they stick their hands in their mouths. And so we thought if there's a new toy, new experience, that we may see some differences in hand-to-mouth behavior. So we gave them this toy. Parents were mad about this because it's an annoying toy, but we felt very terrible. A lot of parents gave it back to us after the study was over. And then we haven't done anything with these data yet, but we collected videos of children eating as well. We had to calibrate the cameras when we first set them up, and it looked like this. So we had to carry these very large checkerboards, and these checkerboards were filmed from each of the 4 cameras. And the idea was the camera could calibrate itself relative to the other cameras, and they were able to collect some calibration data that was intrinsic to the camera to make sure that we would be able to do the rest of the vision algorithm, which I will show you. So anyway, just quickly with the overview here, we would do the home visit, we'd calibrate the cameras at the beginning of the visit, we'd collect the video, we would recalibrate the camera at the end in case someone bumped a camera, which could throw off the whole thing. And then we would process the video. The vision team would actually create 4 camera views, which I'll show you in a second. And then we would send the curated 4 camera views to a team of behavioral psychobiologists led by Kristen Vokline, who would do human annotations. I'll show you what that looks like in a second. And then we had our computer vision algorithm that would run. And the idea was this, until now, has been the gold standard for activity assessment. It's also incredibly labor intensive. And I'll show you exactly how labor intensive in a second. So we were trying to develop something that would allow for studies that would involve more kids. Most of the studies that had used videography prior to us had a handful of kids. And so it's difficult to develop nationally representative data that can inform exposure models for regulation with 4 kids. So we were hopeful that we can develop something that's not too difficult to do that would allow us to do a much larger study. And then so we evaluated it, and we generated some descriptive statistics that we believe are informative for EPA's exposure factors. So anyway, behavioral coding, we had 2 students watch every video, and they would go through each video on a second-by-second basis, and I'm going to show you what they were looking for. They used a software called Noldus the Observer, which is used for all sorts of behavioral science research. And we developed a code book that's probably easier to see here than there, but each video, the students went through it 5 times. So they went through 20 minutes of video in those 2 segments. And they did once looking for positioning. They did once looking for the right-hand positioning, the left-hand positioning, objects. And we were the first ones to publish any sort of data on pacifier use. And I'll talk about pacifiers a little bit more later. But at any second, they code each of these, right? They I think there's another pop-up. Oh, you'll see it in a second. This is a 4-camera view. And the idea behind doing 4 cameras and not 1 or 2 is that we need to be able to see the child's mouth and hands and objects at the same time. And if you set up one stationary camera and the child turns around, kids are unpredictable, believe it or not. You can't see any hand-to-mouth behavior. So we thought at any given point, we would be very likely to capture and be able to fill out our annotation framework. So I mentioned we did 5 passes on each video. And here's a zoom in on the left hand. And within the left hand, we would code at any given second which status it was in, right? And the codes were applied at that temporal resolution of 1 second. And just for sake of understanding the burden, each 10-minute segment, so half of one video from a child for one of these passes takes an hour to an hour and a half. And that's with trained research assistants. So you can imagine why this takes a really long time to generate data, and it becomes very expensive. So the next slide is just some of the output of that coding software. So you can see for each of the 5 different domains, we were able to track movements. This is just a visual display. We obviously have this in numerical form as well. But if you want to zoom in, the object touching mouth, for example, so you can see the time scale at the top, and this is in terms of minutes, and you can see how frequently a child has an object in his hand and the object is touching the mouth. And you can do the same thing for any of these based on the color code. So this is kind of the basis that we would then take our computer model later and compare it for the sake of assessing validity. Okay. Man, I'm sorry about my text being messed up, but we found pretty good reliability. We were meeting our reliability scores between the 2 raters. So, obviously we want to have 2 views of each video to feel confident that there's agreement. Oh man, all my stuff is getting messed up. Okay, so let's switch over to computer vision for a minute. So the first thing our computer model did is it took these existing computer models and identified something called key points on babies. And so you can see what key points are on these images of adults. Our team was able to adapt them for babies, but they are locations on the human body that are trackable and detectable by these two packages. And so when we would run the key points algorithm, it would identify key points not only on the baby, but also the caregiver in the scene. And so the next step is making sure that the computer model knows which human that we're interested in. So we used a different package called Grounded SAM that was designed, given parameters, to identify which human you're actually looking at. So then we would take the key points, we would apply Grounded SAM, and we would only be looking at the baby. We would delete the adult human from our world. We don't care about the adult anymore. We care, we just didn't do anything. All right, and then here's the really interesting thing. So this is a one camera view. Keep in mind that we had 4 cameras all recording at the same time, all assigning key points and selecting out the child. And so what we needed to do is go from 4 2-dimensional images to 1 3-dimensional representation. And so the idea here is that we would assign each of the 2D key points, and then we would triangulate using an algorithm that our computer team developed, where they would take each of the great thing about the key points is that they are consistent points on a human. So we could take the same key points across the different views when we were able to see them, and then we could use that to triangulate a 3-dimensional location, and that would be the location of that particular point in the human body, which is moving us towards where we ultimately want to be, which is being able to track the movements of children. We also had to develop a deep learning additional model that would differentiate when a child had an object in his hand and that went to the mouth versus just the hand going to the mouth, which was tricky, but they were eventually able to get that to work because that is it's important to differentiate those things. And then so we have a plot. What we would do is we would take the 3-dimensional key points for a child's hand. And actually there was not a perfect one for us to use in terms of doing the hand to mouth behavior. So we had to interpolate distances between a couple of key points. And that was our hand. And then we had the same thing for the mouth. We had all the points around the mouth. We had to interpolate between those locations. And so what this plot is the distance between those 2 interpolated 3-dimensional key points. And the idea is as the hand of the child moves further and closer to the mouth, you can actually see that distance shown here. And what we needed to do is figure out, what does an event look like? What does a hand-to-mouth contact look like? And so we decided through observation a threshold that made sense. And this was also aligned with what our human coders determined. But this threshold, anytime the distance went below that threshold, we would count that as an event. So that would be the appropriate distance to say a hand-to-mouth event has occurred or an object-to-mouth event has occurred. And there were some difficult choices to be made that we worked through. So the computer vision algorithm, so the humans were going on a 1-second temporal resolution. The computer does 10 frames per second, so much, much higher. So we had to figure out how many frames of this short distance do we need for it to count as an event. And then the trickier part was thinking about time between events. So if a kid takes an object and goes, is that one event or is that many events, right? And so we came up with a determination that we would count it as the same event unless there was a 4-second duration gap between events. The idea is these objects and hands can deliver dust. And if there's too much repeat contact, it's unlikely that there's a new dust event occurring in the hand going in the mouth. So that was the basis for event determination. And I apologize, I'm going so fast, but we published 2 papers, one on the development of the computer algorithm and one on the application that's more of the distributions that we would use to inform exposure factor development. I have a table here of our estimates of the different distributions of activity for all events, for doers only. So something that surprised me was that a decent number of our children over a 20-minute period had no hand-to-mouth activities at all, and that's possible. Some children have advanced beyond the point where they're going to put their hands in their mouths to explore their environments, and there may be other reasons, but many of them had many events. And so I'm happy to share these papers. The numbers themselves are not that exciting, but they're useful in exposure modeling. We reported descriptive statistics by the type, so by each hand, by object, by all. We did it by doer status. We also tried to assess differences between children who were more developmentally delayed with regard to their fine and gross motor development. And also we divided our children up into 2 life stages, 6 to 12 months and 12 to 18 months. We did not see any statistical differences across those. We weren't sure what we would see. So we're not sure that in the future parsing by life stage or by motor development is going to be all that useful in developing these distributions for use in risk assessment. But these are a direct input into that SHEDS model I showed you before that could be useful in recalibrating the soil and dust ingestion exposure assessment. We also collected data on pacifiers and comfort objects, but we were really only able to work with them with our human annotators. We didn't have enough kids in the population that had pacifiers. Again, we didn't know a whole lot about rates of pacifier use going in, but we found about 15% of the kids that we enrolled in our population used them. And pacifiers are tricky because a pacifier can be a barrier to soil and dust ingestion, but it can also be a facilitator. Some kids keep pacifiers in and they never come out. And some kids drop their pacifiers constantly and they're wet. And if you have a dusty environment, you can pick it back up and reload and be exposed again. So we at least wanted to start developing data, and we can model some hypothetical scenarios involving pacifier use. But it's good to have some data, but it's really, really uncertain. And so during the kids that had pacifiers, we found that they had a pacifier in and out of mouth event once every 4 minutes. But again, highly uncertain, low confidence, but it's some data is better than no data. Okay, so going back to this, in the first part of our study, which I didn't tell you about, we developed these macroactivity distributions. So where children spend time, what the activities they're engaged in are when they're in those different locations, and other parameters that are relevant to soil and dust ingestion. So taking those and combining them with this microactivity data that we've developed, these are going to bolster some of the biggest gaps in this shed soil and dust model. And our hope, and we're working with former EPA people who were released during this administration, but we are going to work with them to update this shed soil and dust model. And hopefully that will give us new data that we can use in risk assessments and in regulatory decision-making around dust and soil. So anyway, that's my first case study. And I will certainly take questions on that after, but I wanted to transition now. So I just spent some time talking about some advances in exposure science, and I think there's a lot more to talk about there. But I want to talk also about this recognition of cumulative burdens that people are experiencing. So my colleague Pete DiCarlo and I have some funding from the Bloomberg Philanthropies to try and better understand the exposure and risk burden associated with living near large-scale petrochemical processing facilities. And I was so excited to start working with Pete because Pete is an atmospheric chemist and an engineer, and he has this amazing mobile laboratory, which is essentially a van with $1.5 million of measurement equipment in it that I barely understand how to use. And my role in the project is Pete gives me all the data that he generates, and I have to tell him what it means, right? So let's dive into that a little bit. Our ultimate goal in the Bloomberg project was to go to some of the densest petrochemical complexes in the United States. But before we did that, we needed to test the van. And so our initial part of the project was a pilot that we ran measurements for a month in an area in southeastern Pennsylvania, in Chester, Trainer, and Marcus Hook, Pennsylvania, so just southeast of Philly. And Pete was able to have his team drive the van in a prescribed route through the industrial corridor and also in some of the surrounding communities. Starting each run took a couple of hours, and he would start at a different hour of the day so we could look at the temporal and spatial variability and of different pollutants that were released by these facilities. But the area we were looking in, while it wasn't Cancer Alley, Louisiana, or Beaumont, Texas, it was a very dense industrial region. It had a number of petrochemical facilities, and it had the country's largest incinerator and a number of other heavy industry facilities. So there were quite a number of different hazardous air pollutants to measure in the air, and the HAPs were our focus for this initial run. So P was able to develop this highly spatially resolute data that we were able to use over the course of a month and feed it into a risk model, which is what I'm going to show you. So this project, which was called the Hazardous Air Pollutant Monitoring and Assessment Project, used Pete's van, drove around, but we also combined it with a more holistic approach. So my colleague Sarah Leupold led a community-based participatory research study with community residents and advocates in the area to develop a health survey and conduct focus groups to talk about people's priorities and what they were experiencing. And the idea is that that would complement the pollution measurements that we collected to tell a fuller story about what people are enduring for purposes of advocacy and policy change. And then what I wanted to do for the risk team was we could do a standard risk assessment with the chemical data that we had, but there's some pretty serious limitations to the way we've traditionally done risk assessment. And I wanted to see if we could try and innovate and better account for the mixture of chemicals that people were breathing and the way those chemicals may interact to elicit disease in organs across the body. And so I'm going to show you this new approach we developed and how it changes the answer to the question about what people are experiencing, ultimately hoping that we would have different and better decisions to protect public health. So a couple thesis statements before I start. I have been bad-mouthing traditional risk assessment so far a lot, and I will continue to. The issue with traditional risk assessment is, remember I showed you the red book and the whole one chemical at a time approach? The deficiency there is when we regulate one air pollutant at a time, the idea is we have to pick a level, right? We need to keep it below a level. And so the way we've done that is we say, what are all the different health effects that are elicited by breathing that chemical? And what's the most sensitive health effect? It was the one that occurs at the lowest dose, right? And what we would do is we would say, that's the level we need to protect against, and we'd set the level there, right? And we'd say, if you protect against the most sensitive health endpoint, there's no reason to expect any of the other health endpoints would occur. And if we were ever only exposed to one chemical at a time, that'd work great. But reality is we aren't. We're exposed to lots of different chemicals at a time, and that's where it breaks down. So a more holistic way to do this is to recognize that if we're exposed to multiple chemicals, each of those chemicals may have multiple targets throughout the body, even if it doesn't elicit a disease by itself at a particular level. When you're talking about 30, 40, 100, 200 chemicals, you could see collective burdens on some of these secondary and tertiary target organs that may push you over the level where you'd actually have an adverse health outcome. Okay, and if we do this properly, we may end up with very different results and come to different conclusions about the need to intervene to protect people. So let me explain a little bit of what I mean. So this is from our paper. It's kind of a hypothetical, but I hope it helps illustrate the point. So each of these circles is a different chemical, and each chemical affects a target organ system. And this is the traditional approach. So you can see here, each chemical is linked to one disease or one organ system. Okay, and they're numbered 1, 2, and 3, right? And so in the traditional way, only the most sensitive one. But if we were to expand this approach and think about all the secondary, tertiary, whatever health effects that could arise from higher exposure to each chemical, we'd recognize that chemical 1, its most sensitive organ system is target organ system 1, but chemical 2 also affects that organ system, and chemical 3 also affects that organ system. And so if we're really only considering that chemical 1 contributes to that outcome, we're ignoring the potential stress or burden from these other chemicals as well. So if you take the same idea and you show, just again, this is hypothetical, if we were to look at target organ system 1, the traditional way, we might come to the conclusion that the level of exposure is not high enough to actually cause a problem. But when we consider the collective burden of those 3 chemicals on that organ system, we would actually see that we'd elicit an effect. And so this is just 3 chemicals, and this is just a handful of organ systems. In reality, we have to account for the fact that there are lots of chemicals and lots of organ systems. So this is something we developed called the multi-effect toxicity database. And I wanted to mention that Carolyn Bijot, who I don't think is here today, was a part of this and did a lot of this work. So I wish she was here so I could shout her out. But this looks a little complicated, but it's not. So let me walk you through it quickly. So on the x-axis here, we have the chemicals that we measured in the HAP-MAP study. So all VOCs, all HAPs that are regulated. On the y-axis, we have the different organ systems that we use in risk assessment to kind of collect the different events. And anywhere you see a circle, we have quantitative evidence that there is a dose-response relationship that exists for that chemical. And the different shapes, they're all the same idea. We just organize them by where the data originated from. So what's notable here is in traditional risk assessment, we go to a resource called EPA's Integrated Risk Information System, or IRIS. Have you guys heard of IRIS before? I know some of you have worked on IRIS things before. But anything that doesn't have one of these black dots in it is traditionally not considered in risk assessment because we're focused on the ones with the dots. Okay. One other thing I want to point out before I go further is this says CompTox. This is a reference to EPA's CompTox dashboard. We use it because it's an aggregator of information about chemicals. None of these are modeled points of departure or dose response relationships, just to be clear. That's another frontier that would be cool to explore in the future. So this is all either from a human study or an animal study for each one of these shapes.
I just want to confirm that Carolyn's online. Just want
Oh, hi, Carolyn.
I'm sorry I joined late.
No worries. Okay. So anyway, each of these symbols is a point of departure. I'll explain what that means in a minute, but we have some data linking exposure and outcome quantitatively. Okay, so here's an example. I think that's benzene. We have a black dot. Benzene is regulated based on its effect on the immunological system, but we have evidence and dose response relationships for a number of other systems that are also affected by benzene that we would traditionally ignore. Okay, most of the chemicals we measured, when you look through what data are available regarding points of departure and exposure effect outcomes, target lots of systems. So this is formaldehyde. When we think formaldehyde, what do we think? Respiratory effects, right? But there's evidence that formaldehyde can actually elicit effects in multiple other organ systems. They're just potentially less sensitive than the respiratory tract. So this is an example, maybe the most extreme one, where there are about 11 health endpoints, but we only consider one. And so if you look across a given organ system like reproductive, in this example, we would consider one chemical as contributing to a reproductive burden, when in reality, we have data that many chemicals also contribute to that same burden. So by doing it the traditional way, we would ignore the effect of all those others. To take it even a step further, some organ systems like the renal system and the endocrine system, do you see any black dots? There are none. So these would be fully ignored, dropped from a risk assessment altogether. We would not consider those effects whatsoever. So let me just talk briefly about what points of departure are. This is a term we use in risk assessment in deriving dose response metrics. So points of departure are things like NOx, LOX, and BMDCs. Are these familiar terms? They're like no effect levels, right? And so they're from tox studies or human studies. And the idea is there's some level below which we think it's unlikely there would be an effect if a person were exposed for a long time over that, at that level. And so to go from a point of departure and turn it into a toxicological value, like a reference concentration, which is what we use in regulation, there's some manipulations that need to be done to account for where the data came from, the type of study, the limitations of that study, et cetera. And so if we have an animal study, we have to consider the study dosing regimen and a dosimetric adjustment to actually physically go from an animal model to a human. But then we also account for different uncertainties associated with variation in the human population, variation and extrapolation across species. If we had a subchronic study, which a lot of our studies that we used for that were subchronic studies rather than chronic studies, and then dealing with the type of point of departure. Low L's are the least preferable because we've not identified a no effect dose, but a BMCL is actually modeled from the full dose response relationship, so we feel more confident in that one. So it would require less of an adjustment for uncertainty. So anyway, sorry, that's boring. But the resulting thing we get is analogous to a reference concentration, but we call them target toxicity concentrations. Okay, back to this. So now we take, you like Pete's cool van, the mom and pop van? I always forget what mom and pop stands for, but this is the mobile lab. It is so cool. I got to ride around in it. I didn't understand anything in it. Okay, so what we wanted to do is show you how to characterize risk for each chemical. So the idea here is with Pete's van, we are able to measure these things in real time and develop maps of over the duration that we measured. We were able to model what a chronic exposure would look like with some uncertainty. And we use that and we compare that to the target toxicity concentration that I just talked about and estimate a hazard quotient. And they're very easy to interpret. Anything equal to or above 1, we would say there is an increased risk of developing an adverse health outcome in that organ system. Anything less than 1, we would assume it's unlikely that that population would get sick under that scenario. And then for cumulative non-cancer risk, this is not a huge deviation from how things are done at EPA now, but we would essentially add all the hazard quotients together within an organ system and get a hazard index. And the interpretation is again the same. Anything above 1, we think we would see an effect. Anything below 1, we wouldn't. And so this is the same METDB, but this is a representation not only of the points of departure, but these are the hazard quotients and hazard indices. So each symbol is a hazard index from the study. So this one is developmental for benzene, and you can see by the color and size coding that the value there would be the hazard quotient for that particular chemical, and that outcome would be somewhere between 0.1 and less than 1. Of course, we have the real numbers behind this, but this is a visual display. And these on the right are the hazard indices for each of the bodily systems, okay? And so, for example, you take neurological, we would be adding all those hazard quotients up, and we would get this hazard index. And in this particular case, this hazard index is above 1. So in this scenario, with our actual measurements, we would expect that there could be increased risk of neurological disease of some sort in this population based on breathing this mixture of VOCs at the levels that they are. So here's where the rubber really hits the road. This is from our paper that I'll show you in a second. But we wanted to compare, if we did it our way and compared that to the way it would traditionally be done, how would things change? And so this would be using the traditional approach where we're only considering those black dots, right? The ones, the most sensitive endpoints. And what do you see? Nothing above 1, nothing really even that close to 1. So the conclusion that you draw from that is we've done a risk assessment for people breathing chemicals at these levels in this community, and we wouldn't expect to have health effects. And so what would that mean for a risk manager? Why do anything? Everything's fine, right? But then if you use the results from our MET-DP, you see that not only do we have some measure of hazard index for every endpoint. So like here's, for example, I think we have renal. Yeah, there's nothing, right? Because we had no black dots in the renal organ system. But we have 5 health endpoints that are above 1. And the interpretation there would be that there is reason to believe there could be increased risk of these 5 organ systems having some sort of adverse effect in this community, given exposures at these levels over time. And so it's likely that if this were in a context of a decision about adding a new facility, a permit, or making a decision whether some sort of intervention needs to take place, this would likely motivate a decision, this wouldn't. And so we argue that this new approach is going to get us closer by holistically accounting for all the chemicals in the mixture and all the places in the body they may affect. We'd have better public health decision making. So quickly, what it means, I hope I've made a case that the old way, the traditional way, is going to lead us to decisions that miss part of the burden of these complex mixtures. Our approach, by accounting for each chemical's full potential for targeting different parts of the body, we believe is closer to the truth, closer to reality. There's certainly uncertainty there, and I'm happy to talk about all the limitations. But we do believe, at least as a starting point, this is not a huge jump beyond how we're doing things in risk assessment. So we think this is going to push risk assessment a lot closer to understanding cumulative burdens than we've ever been. We published this in Environmental Health Perspectives. This was sadly one of the last couple papers before the journal was taken offline, although it's coming back. So I'm excited about that. But what I was kind of surprised by is this is a kind of geeky and technical paper. I think the implications are big for public health protections, but we got a lot of media attention about this. It got covered in the Washington Post and a lot of other outlets. So it was exciting to be able to talk about this. We had a very good reception to this from some of the folks at EPA before the administration changed, and we were invited to present our findings. And what's been even more exciting is in the last 2 months, we've been engaged with some state regulatory agencies that want to actually fund a postdoc to work with us to try and adapt some of their regs to be able to try and use some of these things. So I'm really excited about that. I'm the most passionate when our work gets to change policy, and this would be cool. But I really believe that if we really account for mixtures more holistically, I think we could save lots of people's lives. I really think it means a lot. So anyway, just what we're doing in the future with this is we've gone to Cancer Alley and done the same thing. We have one paper out that's a cancer risk assessment from that work in PNAS, and we're about to submit another paper that's both cancer and non-cancer. Our team just finished measuring in Beaumont, Texas, which is another heavy duty petrochemical community. But the cool thing about this and getting closer to cumulative risk is I showed you one route of exposure. It was all air pollution, but can't pretend that air pollution is the only route or pathway of environmental exposure that we encounter. So I have students working on other routes and other exposure contexts. So I have another student who is working on experiences of hairdressers and beauty salon workers who in the course of doing business are exposed to a lot of different personal care products, the air emissions and the dermal emissions from that. And I have another student who's working on a project looking at sunscreens and the different chemicals that are involved in sunscreens. So I'm excited about merging multiple pathways in the future because it can be done. It just means going through and curating the METDB for a different route, different pathway. I talked about this, so I'm going to skip that. But anyway, just kind of going back to what this whole thing is about, risk assessment is super useful. And I think it gets a bad rep because a lot of the methods we use are really outdated. But there are a lot of opportunities and there's a lot of receptivity to making risk assessment better and actually taking fuller advantage of the science that we do here, that you do here. And so I'm excited to excite other people about working on these sorts of things because I think times are going to change and we're going to retreat from this deregulatory attitude we seem to have right now. And the evidence that we've been generating in the interim is going to be primed to really allow us to build back better than we've been before. I'm hopeful in that way. So anyway, I'll stop. Thanks very much.
This was amazing. I teach in our core class, I teach the risk stuff, which I mostly learned from Joe. And now I'm gonna have to rewrite all my lectures, so thank you very much.
Sorry for the extra work, but thank you.
Yeah, I mean, the traditional approach that you started with is so unsatisfying. and students are left scratching their heads. And you know, especially when we get to the uncertainty factors,
Right.
you know, when you go from animals to humans and factor of 10, from this to that, and another factor of 10. What is the factor of 10 based on? It's based on like, just pull in, yeah, 10 fingers, yeah.
There's some debate over where it came from, but that's, I think, 10 fingers. Yeah.
Thank you.
Great talk. I have a lot of questions, but I think the first one I want to start with is, so your first case study, the lead, the dust digestion one. I mean, I did a lot of work on house dust myself, and lead. And so you said it was, I just want to kind of speak to who you sampled and how that's often, you know, right, not the population that's at risk of, you know, lead exposure from dust ingestion, right? We know it remains a big health disparity and EJ concern, and that wasn't the population largely, right? And so it's a methods paper, but it is, if I understand it, you want it to be the basis of new exposure factors, right? And so you're capturing, you know, you're using that data to capture distributions, right? So do you think the distributions are reflecting the distributions of the general population, especially highly, you know, populations high at risk? And did you guys do any sensitivity checks to kind of test that assumption? Because I'm a little, you know, I just wonder if your range is actually reflecting the range to encompass highly vulnerable populations.
It's a totally appropriate and excellent question. And the answer is no. I don't think it reflects the true population distribution. And that's why I wanted to emphasize that it's methodological, because I think we need to do another study using this or a similar method that is very deliberately designed to capture the most vulnerable populations, because the home environment could be different. Right. I mean, we were not trying in what I showed you today in the microactivity assessment to actually model specific chemical exposures. And I know that dust composition from house to house can be very different. So I do think we need a better characterization of what's in dust from house to house. And I think that needs to be very sensitive to all the different stressors that may influence what's there. But I don't believe that, I'm not confident in our assessment of variation, but I do think what we've developed in terms of variation is better than what's out there now and what's being used. So our hope with this was never that this was the final definitive study on all microactivities. It was a proof of concept almost that we can capture and generate distributions of microactivity behaviors with this approach.
Thank you.
Julie.
And just building off of that a little bit, I mean, I think the point that it's methodological helps your case, because why, is there a good reason to think that other children are going to behave differently in terms of their hand to mouth behavior?
Well, I don't know.
And right, I don't know either.
mean, yeah,
But
I don't
I
know.
was thinking, I started doing some work with the pediatric dentistry clinic folks, and they're just actually on our, they're like right below us, probably, I can hear us. But I thought about teething and how teething, and because that was interesting to me that you didn't see a difference between 6 month and 12 month and 24, when like, I think there's different stuff, let me just say it that way, going on, and when kids are teething, that's when they're like off, like much more free, like they're putting their hands, they're putting anything in their mouth because they're bothered by whatever's going on. So I was trying to see if the ages and stages capture teething. It doesn't, of course. But I wonder how much that could change and impact, you know, individual behaviors and how to deal with that.
Or just like if an infant is adequately fed, right? Because maybe if they're slightly malnourished, their microactivity behaviors would be different.
Sure.
Yeah, but I was just wondering if there was a way to try to test some of those assumptions with the limited data in the literature. I don't know.
My answer was like, if we had a bigger study, we could. I don't think we were powered to really truly assess the differences. I think that was kind of like, let's try it because we collected some of the data. But I do think we need a bigger study because I think those things matter. But if we were able to capture even crudely the boundaries of what we're dealing with, the idea is we develop population mediums, and we want to protect the high-end kids, the kids who have the most activity. And we had some high-end kids. So I am hopeful that the distributions we have capture that maximum and allow us to put together estimates of ingestion that'll result in protective regs.
Great talking.
Thanks.
Personally, it's always a bummer. I have a teething baby at home right now. It's a bummer to be reminded that I should probably bathe my children more often and mop my floors more often. But I wanted to ask about the cumulative hazard function. Have you looked at public drinking water at all yet in this capacity?
We have a postdoc in my group that's looking at TSCA regs and actually looking at groups of chemicals in both drinking water and air, and that work is underway. So we'll see. Yeah, but I think the same idea would apply. And I would be really interested in the context of unregulated drinking water, like wells. I think for a lot of our regulated drinking water, we started doing some preliminary calculations, and it doesn't look that different unless you have long-standing exceedances. But I think the unregulated wells would be really interesting.
There's Caroline online.
Hi, Carolyn. Good to see you.
Hi, great, really cool projects, and I'm sorry not to be there in person. I have a question about the cumulative risk assessment work. What do you think about using something like that approach and the mom and pop measurements to identify like data gaps, like where the levels are much higher than something like a value from Comtox, but there's no IRIS or ATSDR?
When you say levels, do you mean the exposure levels?
Exposure. Yeah, like I'm thinking especially in Cancer Alley.
Well, I mean, one of the things that I didn't get a chance to talk much about is the variation in quality of a lot of the points of departures we use, which is a limitation in risk assessment. Some of the values, the IRIS values in particular, especially the modern ones, I feel really good about those. Those are pretty solid values. But some of them are from some study that happened in Yugoslavia in 1972. And sorry if I offended. That was a great study. But
it was 78.
all right. But anyway, that's a limitation. I mean, I could rattle off the limitations all day. The issue, though, is that we are making the best possible use of data that exists. We know that we're not providing a true, precise estimation of what the risk is, but is it enough to support better decision making? We believe that it is. And I think we have to allow ourselves to get to be good enough in this regard, because I think putting resources into getting that point of departure exactly where it needs to be what is the opportunity cost of something else we could do to protect population health? So something that we are looking into doing as we further develop the METDB would be assigning each point of departure a confidence rating based on the origin of that point of departure. So you could actually filter out, if I don't want to include the studies from 1972 or whatever, we would assign them a low confidence rating and we'd rerun without them. And it would shrink the effect estimates for people, and that's okay. So I think there's a lot of things that we can do to improve the confidence in what we're doing. But this is a starting point and one that we're pretty proud of.
For sure. I'm just thinking of even using the data you've collected to make something like a list of the chemicals where like we're at using the most uncertainty factors and like to help prioritize future research.
Yeah, I think we could take the chemicals where we don't have a lot of points of departure, where there seems to be a lot of exposure, and prioritize those for future, even some of the in vitro stuff, I think, as a starting point. And there are people at EPA that are working on developing these in vitro to in vivo models. So we can take a cell culture and try and say something about what it means when humans are exposed. It's imperfect, but it would get us closer. But it would allow us to think about some of the exposures that don't get valued very high in our current model because we lack good tox data, especially when there's evidence that there's a lot of exposure.
Thank you.
Oh, no, please. Go.
Yeah. I think this is how risk assessment should be done. And I'm wondering whether this new approach also puts a new light on how we look at the definition of cancer cluster. I'm not sure whether you heard of that case at Roanoke College in Virginia, I believe. So it was a cancer hotspot among faculty and students. And then, but what they said eventually is because not all the individuals got the same type of cancer, it was not a cancer cluster and there was no problem. So it was just an accident.
Interesting.
Statistical noise. And I somehow I believe your approach is also getting at that, how we define cancer cluster.
Well, and a lot of the carcinogens that we've measured as VOCs are multi-site carcinogens, and we might pick one cancer site as the one to focus on because it's the highest potency out of all the different possible sites. Yeah, no, that's a good point.
Yeah, and I thought you should truly be proud. This is amazing work. And I was looking at, and of course, the quality of the evidence behind is going to make your cumulative risk assessment better and better. And so I was very intrigued by the fact that the cardiovascular looks so low and like not contributing much. And it's just, I think, still a limitation of how behind this environmental cardiology and toxicology, vascular toxicology is. And so I wonder, what do you think about this?
We inventoried how many points of departure were available by different organ system, and we found that developmental had the highest. And we did find inconsistency in how often there were points of departure for a lot of different endpoints. And like you're saying, it may not be that there aren't relationships. And when we had a blank spot in that matrix, it's not because there's no relationship, it's because we don't have any data. And it's difficult to say something doesn't affect a system. But I do believe for certain organ systems like cardiovascular, we just don't have a lot of great toxicological data. Most of what we have is not epidemiology, it's toxicology. And so I do think some of the new approach methods could be a way to start figuring out where are the blank spots here where we could do more to learn more. So I'm hopeful we'll get better in that regard. Yeah.
How many bands of those are there? Like, is there, we all need a band like that.
So when we did Southeastern Pennsylvania, we actually used a van that was the model for the one that we ultimately built and took to Cancer Alley. We were talking about building a second one, but it sounds very simple when I say we have this cool van and we just drive around and push a button and we're good. It takes a huge team of people to run, and then the processing time for all the data we get from it is half a year for a single month's run. So it's expensive. There's more of a mobile monitoring community developing. I flattering myself, Pete's really good. I think he's one of the pioneers in it. And I think we can do PM, VOCs, all metals, all sorts of things. So, but I think I think the technology for the instrumentation has become more mobile and more portable. So while it's still expensive, it's actually possible to run one of these things. Whereas, 10 years ago, this would have been not able to be done.
What if we could partner with Google, right? Aren't they running their maps? Seriously, like some sensors on their trucks, they're already going.
Yeah, could be.
Yeah, well, maybe it's not so bad hard. I wouldn't know how to get it.
One other point I wanted to make that I didn't was part of the reason we have to go out with a mobile lab is because the monitoring infrastructure, especially for VOCs, is awful. We do not monitor them. Our monitoring infrastructure for criteria pollutants is a lot better, but still not amazing. And in places like Cancer Alley, which I didn't talk about today, there are so few monitors, and the existing data we have for what people breathe is all model-based. And the origins of that model-based data is what emitters report to the state, who reports it to EPA and analyzes it. So you can imagine, maybe there's a conflict of interest in self-reported data about emissions. And so in our other paper, which I didn't talk about today, I'm happy to share it with anybody. We did a paper on ethylene oxide where we took modeled estimates and compared them to what we really measured in real time. And ethylene oxide is a nasty mutagenic carcinogen. We found levels on average that were about 10 times higher than what the models suggested for a mutagenic carcinogen. Just wild. And there's so many chemicals. That's one of the most high profile chemicals right now in terms of organics. So a lot of work to be done to augment our monitoring infrastructure, especially in places where we expect people to be highly exposed to lots of things. And then the last point I'll make, sorry, I'm going on and on. None of this that I showed you today accounts for all the other stressors that people endure. None of it does. And those things are well recognized to have biological implications that could make us more vulnerable to chemical exposures. We suck at that in risk assessment. We're nowhere close to being able to quantify it, but we need to consider it in risk management. So while we are working on the science to get better about understanding the influence of those factors, we need to do more now when we're making decisions to at least make uncertainty factors or something, come up with some way to account for those factors and how they influence people's well-being.
Amazing.